This is part 2 of appraising a clinical trial. In this part, I'll be going through the list of relatively easy questions you should ask, and I'll be grouping those questions based on standard sections of a scientific paper. So let's start with the title. There are two related questions here. First, does the title clearly communicate the study's content? And second, is it free of sensationalism? While there are certainly great and influential trials that have terrible titles, when I see a title that doesn't really give me any clue as to what the trial was looking at, my expectations start to drop a bit. Also, a well-designed trial, described in a well-written paper, will be as objective and unsensationalistic as possible, since the findings will speak for themselves. We'll skip the author list for now, but I'll come back to it in part 3. As for the abstract, as I described in part 1, its purpose is to inform you as to whether the rest of the paper might be relevant to your patient. So while you aren't ignoring it, you don't really need to appraise it per se. Next is the introduction. The introduction is the least critical of the 4 major sections of the paper, so you don't need to spend as much time on it. You want to ask whether the authors have reviewed relevant background literature, and is their trial original? That is, did the authors do their homework before starting it? This is important because if the authors have not demonstrated an understanding of the previous research on the topic, it should make you skeptical that they've asked an appropriate clinical question or one that has not been definitively answered already. Also, the introduction is the optimal place where that clinical question should be stated, preferably in simple and clear PICO format. Who were the patients? What was the intervention given? What was the control? And what was the primary outcome? Then we have the method section. The method section often gets shortchanged in the appraisal process because it's technical and boring and seems to require knowledge of study design. But there are some questions of the methods that even novice practitioners of EBM should get into the habit of asking. First and foremost, how specifically are the methods described? Ask yourself if a motivated reader could accurately reproduce the trial, not the same exact results per se, but the trial itself, using the method section as their only guide. This should be possible with a well-written paper. 2. Who were the study subjects? How were they recruited? And what were the exclusion criteria? This is important because if the trial had tons of reasons why potential subjects were systematically excluded, it limits how well the trial can be generalized to other populations and may affect how confident you can be that the study applies to your specific patient. For example, if the trial is an RCT of a new chemotherapy drug for cancer, but patients were excluded if they were over a certain age or had kidney or heart problems, then how can we know if the result can be applied to an elderly patient with heart failure? We can't. Next question, number 3. How large was the sample size, and was the desired sample size calculated ahead of time? This 2-part question is a little more advanced, but problems with inadequate sample size are so common that it's critical to always consider it. In short, a trial needs to have enough subjects that there is a high probability of detecting a clinically relevant effect if it exists, and therefore there will be a high probability that the intervention is not beneficial if the trial shows it to have no benefit. Now, that may be a little confusing, so in other words, we don't want to reject beneficial therapies just because the trial was too small to demonstrate that benefit. Sample size is related to something called the power of the study. The power of the study is the probability that the study will detect a difference between the intervention and control groups, if a true difference exists. By convention, and it's arbitrary, the goal power for a well-designed clinical trial is 80%. This means that if an intervention is beneficial, there should be an 80% chance the trial will detect that benefit. Adequate sample size for a trial can be calculated based upon our desired statistical power and how large a clinically relevant effect would be. Unfortunately, studies are frequently underpowered due to difficulty with patient recruitment, which may lead to incorrect conclusions that an intervention has no benefit. Also, unfortunately, the size of the anticipated treatment effect can be back calculated from an estimate of how many patients it will be feasible to enroll into the trial. This is a little shady, but there's no way to know the investigators did this other than by questioning whether there seems to be a rationale given for the anticipated treatment effect that they're looking for, and this is rarely discussed in a paper. Good sample size calculations should also account for loss to follow-up. For example, if the authors expect that 10% of the recruited patients won't complete the study, the number of patients they plan to recruit at the beginning needs to be correspondingly larger. Over time, desired sample sizes have tended to increase, particularly in major cardiovascular trials, which currently can have tens of thousands of patients. This is because the incremental benefits from new treatments are of smaller and smaller magnitude as the care for cardiac patients has gotten better and better. We also don't just consider inadequate sample size to be a problem leading to the rejection of beneficial therapies, but they can also be a problem leading to the acceptance of useless therapies. While p-values and confidence intervals attempt to account for this issue, small sample sizes can still lead to inadequate randomization and other forms of systematic bias, which can be more difficult to detect than when the numbers of subjects are much larger. Question 4. Was the trial controlled, and what was the control? So first, any trial that lacks a control is going to have very limited validity. If every patient in the trial receives the study intervention, how could one ever conclude that the intervention was beneficial or not? So if there's no control, you probably want to stop right there and go look for another paper. But just because there is a control doesn't mean it's an appropriate one. There are 3 types of controls in clinical trials. The control can be a placebo, which is usually a dummy pill made to look and taste like the intervention drug, but can also be something like sham surgery, where a patient is taken to the operating room, placed under anesthesia, and a small superficial incision made, but no actual operation performed. However, sometimes the disease being studied is both serious and already has effective treatments, which would make a placebo-controlled trial not ethical. In that case, an intervention can be compared against a single established alternative. For example, in breast cancer, if we know that a specific hypothetical chemotherapy regimen cures 20% of patients, we can use that as the control against which we compare a new investigational chemo regimen. The third type of control is a little more nebulous. It's called conventional treatment. Conventional treatment is used as the control in situations where there really is not a specific single established alternative, but more like a general approach. So for example, when protocols were developed to provide early goal-directed therapy in sepsis, there wasn't a specific drug or alternative protocol to compare it against. Instead, protocols for early goal-directed therapy were compared against conventional treatment, which included some combination of fluids and pressors at the discretion of the individual treating physicians. While conventional treatment may feel like a less scientific control than the others, it's more real-world and therefore may lead to better generalizability of the trial than if the authors had arbitrarily chosen a single established intervention, which is only sometimes used. One pitfall of relying on a study which used conventional treatment as the control is that conventional treatment changes with time. So for example, the initial trials back in the 1990s of early goal-directed therapy in sepsis showed a benefit compared to conventional treatment, whereas more recent trials of early goal-directed therapy have failed to do so. That's because conventional treatment for sepsis has gotten much, much better in the past 20 years. And this hints at the broader problem of appraising and applying evidence that's old, even if it otherwise seems outstanding. 5. Was the trial randomized, and how is the randomization performed? Any trial which is not randomized is going to have very limited validity due to the inevitable presence of selection bias. After all, there must be some reason why the intervention patients were chosen to receive the intervention while others were not. Even if the study investigators attempt to either adjust for that bias or explain why the patients in the 2 arms were not different, you should still be very skeptical. In terms of how randomization is performed, computer randomization is the gold standard. All kinds of alternative systems have been used for assigning patients to the study arms, including things such as basing it on patient birth date or literally picking numbers out of a hat. While these systems seem like they should work, they actually can fail. One of the biggest reasons is that they prevent something called allocation concealment, which is a procedure implemented to prevent the investigators who screen and recruit patients from having any conceivable influence on the randomization process. Next, was the trial blinded? A single blinded study means that the subjects are unaware of whether they've been assigned to intervention or control. A double-blinded study means that both the subjects and those tasked with assessing outcomes are unaware. Sometimes a study cannot be blinded. For example, a study of major cardiovascular surgery or a study of a behavioral or dietary intervention. But in the cases where blinding is not possible, it's critical that the measured endpoints be objective. For example, imagine we had a randomized trial of aortic valve replacement versus medical therapy in patients with mild aortic stenosis. The trial would be uninterpretable if the primary endpoint was the patient's reporting of their subjective symptoms. And that brings us to the endpoints. What were they? Were they objective or subjective? Which were so-called primary endpoints and which were secondary? Which endpoints were identified in post hoc analysis? Let's take a look at these one at a time. As a general rule, objective endpoints are preferable over subjective ones, but how much preferable depends upon the adequacy of blinding. In a perfectly double-blinded trial, the question of objective versus subjective shouldn't matter, and if anything, a subjective endpoint regarding symptom control might be seen as more patient-centered. But the less certain we are about blinding, the more important it is to have an objective endpoint. Regarding primary versus secondary endpoints, the primary endpoints are those for which the trial was principally designed. They are the O in the PICO format. Primary endpoints are the outcomes for which the study was powered, that is, the sample size was determined based upon the size of a clinically relevant effect for those outcomes. Secondary endpoints are other things that the investigators measured and looked at, but for which the study may or may not have been adequately powered. Secondary endpoints can be predetermined, but they can also be identified in post hoc analysis, which is when investigators look at the data after the study has been completed for any statistically significant associations that were not expected. For several reasons, as a practicing clinician, you should only pay attention to the primary endpoints. A discussion of secondary endpoints may be interesting. They should definitely be used in the scientific process to refine hypotheses and to help design new trials, and they can sometimes help to identify biases that were present in the trial being appraised. But secondary endpoints should not drive care decisions, since many of them are statistical flukes and don't hold up on follow-up studies. There's actually a significant problem with clinical trials being spun as a so-called positive result based on only the presence of a statistically significant post hoc secondary outcome. Such a trial is not positive. If the primary outcome was not different between the intervention and control groups, the trial should be considered negative, irrespective of what was going on with the secondary endpoints. And to close out the method section, I'll discuss the difference between intention-to-treat versus per-protocol analysis. Intention-to-treat analysis means that when all the data has been collected and the investigators are calculating p-values and confidence intervals and the like, they consider all subjects to be assigned to the same intervention versus control arms to which they were originally allocated at the beginning of the trial. In contrast, in per-protocol analysis, investigators only consider those patients who completed the study in the arm to which they were initially assigned. Now, you might ask, why would these be different? That is, why would a patient start a trial in one arm and end in the other? Well, there's a lot of reasons. One of the most common is a patient who starts in the intervention arm, but then develops significant side effects, correctly assumes that they are in the intervention arm, and therefore stops the intervention. Another reason is when a patient starts in the control arm, but proceeds to get sicker and sicker until they or their physician insists on them being unblinded and then receiving the intervention under study if they had been in the control group to begin with. To most people, it initially seems intuitive to analyze per protocol. After all, if you as a treating clinician want to know if a medication will work for your patient, you don't want your conclusions to be thrown off by patients who are non-compliant, particularly if you feel very confident that compliance won't be a concern for your particular patient. But actually, it's really important to analyze data according to intention to treat. Why? Here's just one example. Consider a hypothetical randomized controlled trial of the surgical resection of a locally advanced lung cancer compared against conventional treatment with a primary endpoint of mortality at 1 year. Let's say that 100 patients are recruited. Randomization initially places 50 patients in each arm, and the arms have equal levels of morbidity among their patients. Now let's suppose because of the lung cancer that these patients have, 5 of those assigned to surgery will become too ill to undergo the surgery before it can be performed. If investigators used a per-protocol analysis, they would say that these 5 patients should be excluded from the analysis since they did not undergo the intervention. However, they won't necessarily identify the corresponding approximately 5 patients in the medical arm who also got too sick to undergo surgery within that same time interval. So now, before the trial has even gotten underway, we can see that the 50 patients in the medical arm are on average inherently sicker than the 45 remaining patients in the surgical arm. The investigators have, in effect, ruined their randomization, introducing systematic bias which can make an ineffective treatment appear effective. So now the hard part is over. Appraisal of the method section is the most difficult. We'll now move on to talking about the results. So almost always in a randomized controlled trial, the very first result listed and the first figure concerns the randomization process. The question to ask here is, how good was the randomization? And randomization is not about making sure the 2 arms are nearly equal in size, but rather were any baseline characteristics remarkably different between the 2 arms. For example, were the average ages, distribution of genders, and the prevalence of baseline medical problems in the intervention and control arms about the same. You can imagine that if the patients in one arm seem to start off sicker than the other, that's going to influence the trial results. Keep in mind, just because there's 1 or 2 baseline characteristics that differ between the 2 arms does not necessarily mean that the trial is invalid, but you should keep it in mind when trying to interpret the rest of the results. Also, provided that allocation concealment was incorporated in the study design, imperfect randomization is not a mistake on the part of the investigators, but rather just bad luck. Next question, what are the results? Implied in that is the question as to whether or not the primary endpoint occurred at a different rate in the intervention versus control arms. If there was a difference, and this difference is greater than what would have been expected from chance alone, we say that it is statistically significant. I alluded to this before, but when there is a statistically significant benefit from the intervention in preventing the primary outcome, that trial is labeled a positive trial. If the intervention performs similar to or worse than the control, that trial is labeled a negative one. As discussed in my video on why most published research is wrong, the positive versus negative trial dichotomy is really problematic, but it's currently typical practice to use this terminology. Question 3 for results. What was the dropout rate, meaning how many patients did not complete the study? Dropout rates adversely impact the study's power. That is, if too many patients drop out of the study, the investigators may lose the ability to measure a clinically significant difference between the intervention and control arms. This is why dropout rates should be considered when making a sample size calculation during the study design. Also about dropout rates, it's important to ensure that the rates are similar in the 2 arms. If more patients drop out in one arm than the other, it will introduce systematic bias, which can either make the intervention look better or worse than it actually is. For example, consider a placebo-controlled trial of a new cholesterol medication, statin, involving 1,000 patients with heart disease, in which serum LDL, that is so-called bad cholesterol, is the primary endpoint. The average baseline LDL is 150 among the 500 patients in the placebo arm and 150 among the 500 patients in the intervention arm. Randomization, at least for that one factor, is perfect. Now, after the 6-month trial, the average LDL in the placebo group is 155, while the average LDL in the intervention group is 142, with non-overlapping confidence intervals. Looks like a positive trial, right? Statin is a success. However, consider how unequal dropout rates might impact the interpretation. In the placebo arm, 10% reported adverse effects and 0% of patients dropped out, while in the intervention arm, 25% reported adverse effects and 20% of patients dropped out. This should make us pause before buying any stock in statin. Yes, among patients who did not drop out, it was successful, but we have no idea what would have happened if we could have included all of the recruited patients. It's likely that many of those 20% who dropped out did so because of adverse effects or because they weren't seeing a benefit to the drug in the event of imperfect blinding of LDL levels. And if they were included in the analysis, it could have raised the average LDL at 6 months to the point that those confidence intervals were then overlapping. Also, we have no idea what happened to those 20%. Dropout patients aren't just those who stopped taking the medication, they are patients who stop being part of the study altogether. They don't show up for visits, don't return phone calls, and don't get follow-up tests performed. For all we know, those patients could have died from allergic reactions to statin. And intention-to-treat analysis can't fix this problem. The investigators literally don't have access to the information of dropout patients. So the bottom line, dropout rates should be low and roughly equal in both arms. And the final question in the results, do the figures accurately represent the data? If the figures are a mess, it doesn't necessarily invalidate the study. However, it should make you more suspicious of everything else. In addition to the title, the figures in a paper are what draw readers' attention, and they are what will be shown in PowerPoint presentations during grand rounds and other medical talks on the topic throughout the world. If the authors can't get the figures right, it suggests misunderstanding, poor quality control, or just laziness, none of which inspires confidence that they got the rest of the analysis correct, especially when much of the math that goes behind the analysis is invisible to the reader and can't be easily checked. Now, the last section of the paper is the discussion. Hopefully, because you've read and analyzed everything that's preceded it, you've already developed your own opinion about the results. But keep in mind that the investigators have been spending years thinking about this clinical question, while you've maybe spent 20 minutes, so they might have insights that haven't yet occurred to you. In other words, despite what others might tell you, it's worth reading the discussion. 3 questions here. First, do the conclusions follow logically from the results? That's self-explanatory. Second, do the authors make comparisons to the results of similar studies? For example, you want to know whether the results of this specific trial are consistent with the results of prior trials that ask the same or a similar question. And last, did the authors discuss limitations of their trial, which is another way of asking, did the authors identify sources of potential systematic bias? All trials have limitations: small sample size, imperfect randomization, lack of allocation concealment, excessive exclusion criteria, lack of blinding, unstandardized control, higher asymmetric dropout rates, or the use of surrogate or so-called soft endpoints, which will be discussed in Part 3. Any author who claims their trial to have no limitations is demonstrating an inability to reflect objectively on their work, which suggests a predisposition to overconfidence and to spinning the results in an excessively positive way. So those are the 20 or so easy questions to ask when appraising a clinical trial. These are the questions that I would expect a clinical medical student to be able to answer without too much difficulty. In part 3, I'll discuss the challenging questions appropriate for trainees with more experience, either with clinical care and/or clinical research methods.